Good morning, everyone, and welcome to the Tyro MDS platform. We are thrilled this morning. I am personally thrilled to have colleagues who are going to be talking about a topic that is slightly different than our usual topic of presentation on Friday mornings. We are joined this morning by Dr. Nami Suzuki, who is a distinguished endocrinologist at the Ito Hospital in Tokyo, Japan. She is a board certified. She's board certified both in endocrinology and in thyroidology. She has been awarded the prestigious research award from Japan Thyroid Pathophysiology Research Association. And as you will see, she has the opportunity to be able to mine an incredible amount of thyroid disease within the Ito Hospital records, which gives her a unique opportunity to be able to discuss a topic of great interest to us this morning. I am joined this morning by my colleague and friend, Dr. Terry Davies, who is the Florence and Theodore Baumritter Professor of Medicine at the Icahn School of Medicine here at Mount Sinai. Dr. Davies trained in the United Kingdom, which explains why he has this very funny accent. And then he spent time at the NIH before joining the faculty at Mount Sinai. Dr. Davies has had an extraordinary academic career with well over 400 peer-reviewed publications. His research is primarily concerning endocrine pathology and physiology, with special emphasis on immunology and genetics, as well as autoimmune thyroid disease. Dr. Davies directs a very successful research laboratory at the VA, within the VA research program, where he has received multiple VA and NIH funding grants over his illustrious research career. He is also past president of the American Thyroid Association and a member of the prestigious American Association of Physicians. In 2010, he was awarded the John B. Stanbury Medal for Thyroid Physiology, and he is therefore eminently qualified to discuss this morning's research presentation. So, Dr. Suzuki, Dr. Davies, I welcome. Thank you for your time and effort in carving out what I look forward to as a really informative and highly educational discussion this morning. So with that, let me have Dr. Suzuki begin the talk this morning. And as always, I encourage all of our listeners to send in questions, and we will do our best to get to those questions before the end of the hour.
So good morning, everyone. My name is Nami Suzuki, and thank you for having me here today to give a presentation about my research. I'm going to talk about a primary thyroid lymphoma, which is a rare thyroid malignancy that accounts for 0.6 to 5% of all thyroid malignancies, 1 to 2.5% of all malignant lymphomas, and 2.5 to 7% of all extranodal lymphomas. I appreciate this opportunity, and I look forward to discussing this topic with Dr. Davies later. So let me begin with a little bit about our hospital. So Ito Hospital, located in Tokyo, was established in 1936 as a private hospital specializing in thyroid diseases. I have been working for this hospital as an endocrinologist for more than 10 years. So I have nothing to disclose. This is the paper that I would like to discuss today, and before I get to the main point, I need to give credit to Dr. Watanabe for this paper. She's my mentor and co-author because primary thyroid lymphoma was one of her lifelong works, and she guided me and helped me a great deal to complete the study. As you may know, primary thyroid lymphoma, abbreviated PTL, usually develops in thyroid tissue in patients with Hashimoto thyroiditis. In fact, according to previous reports, 60 to 94% of the patients with PTL had Hashimoto thyroiditis. However, the study initially focused on patients with PTL that develops in Graves' disease, inspired by an encounter with a patient who was newly diagnosed with Graves' disease and showed a low echoic lesion in the thyroid on ultrasound, which turned out to be PTL. My experience with that case made me wonder if there were any differences between any difference in the characteristics or prognosis of PTL based on the background thyroid autoimmunity. So PTL has been reclassified according to the revised European American classification of lymphoid neoplasms, as well as the WHO classification for neoplastic disease of the lymphoid tissue. So according to the Thyroid 11th edition, PTL is classified into the following types, and most of them are non-Hodgkin lymphomas. Diffuse large B-cell lymphoma, DLBCL, which is the most common type, accounts for 40 to 100%, depending on the reports, with a median of 67%. So DLBCL is described as an aggressive lymphoma because it shows rapid growth in the neck. Here are the typical images of DLBCL. The ultrasound image shows a diffusely enlarged thyroid with a low echoic lesion. Below the ultrasound image is the thyroid specimen obtained by open biopsy. The white lesion is lymphoma tissue. The upper right is a microscopic finding of the specimen. The low power view shows diffuse infiltration of lymphoid cells accompanied by partial necrotic tissues. The lower right is a high power view showing large lymphocytes with irregular nuclear contours and condensed chromatin, and these lymphocytes are positive for CD20 on immunohistochemistry, representing B-cell origin. The second common type is marginal zone B-cell lymphoma of MALT type, which accounts for 19 to 28% of PTL cases. Compared with DLBCL, MALT lymphoma is described as an indolent lymphoma because it grows slowly. The typical images of MALT lymphoma are shown here. The ultrasound image shows a low echoic lesion in the thyroid. A thyroid specimen was obtained by thyroidectomy, and this picture shows a specimen after formalin fixation. The partial white area indicates lymphoma tissue. On microscopic examination, a dense and nodular infiltration of lymphoid cells was seen in the low power view. In the high power view, small to medium-sized lymphocyte with slightly irregular nuclear contours and condensed chromatin were seen. So these lymphocytes were also positive for CD20 on immunohistochemistry. So following these two types, mixed tissue types of DLBCL and MALT lymphoma, follicular lymphoma, and other minor types such as Burkitt lymphoma and small lymphocyte lymphoma are the subtypes. So in 2000, Derringer reported a study of 108 cases of PTL, showing that 94% of the patients had Hashimoto thyroiditis, and they classified the patients by clinical stage, which is based on the Ann Arbor classification and pathological types shown in the table on the left. This study showed that high clinical stage and histology of DLBCL are the factors associated with the prognosis of PTL. They then concluded that risks of death with PTL, shown in the table on the right, were clinical stage 2E or higher, histology of DLBCL rather than MALT lymphoma, and parathyroidal soft tissue and vascular invasion. However, even though the original definition of PTL used in this study was lymphoma that presented primarily in the thyroid gland tumor, the study included patients with stage 3E and 4E. Stages 3E and 4E contained lymphoma lesions on both sides of the diaphragm, suggesting that the original site of lymphoma was uncertain, and it may not be PTL, but typical malignant lymphoma. Then in 2011, a retrospective study of 171 patients with PTL was reported. This and the following two studies were reported by Ito Hospital, and the author was Dr. Watanabe. The study included only the patients with PTL whose stages were 1E and 2E to avoid the inclusion of lymphoma originating from other sites. This study showed the 5-year overall survival and event-free survival rates of these patients, which were 85% and 79% respectively. The incidence of PTL in Hashimoto's thyroiditis, which was 0.56%. And the prognostic factors relating to overall survival and event-free survival, which were age, erythrocyte sedimentation rate, and pathological diagnosis. Treatment methods for PTL are radiation, chemotherapy, and combined modality therapy, which consists of radiation plus chemotherapy. The treatment is usually determined by the pathological types of PTL and staging. Since 2007, rituximab, an anti-CD20 antibody, began to be used as a new regimen for PTL in a hospital. Then another retrospective study that targeted 42 patients aged over 60 with DLBCL that required combined modality therapy was conducted to evaluate the then new chemotherapy regimen. The study concluded that rituximab-containing combined modality therapy is effective for elderly patients with DLBCL, increasing 5-year overall survival rates from 71 to 87% and decreasing relapse rates from 21 to 7%. In the third study, we conducted a retrospective study that targeted only patients with MALT lymphoma and compared the prognosis between the treatment methods. In the left figures, the 5-year and 10-year overall survival and an event-free survival of the patients were shown. In the right figures, overall survival and event-free survival are shown by treatment methods. We concluded that MALT lymphoma with stage 1E and 2E responded well to all treatment methods, which consisted of external radiation and combined modality therapy, and had a good prognosis since the 5-year overall survival rate was higher than 90%, regardless of the treatment methods. So this is what we know about PTL from the previous reports. Hashimoto's thyroiditis is believed to be a basis for PTL, and having Hashimoto's increases the risk of PTL 67 to 80 times higher than the general population, but this trend was not seen in the patients with Graves' disease. The prognosis depends on clinical stage and histopathology, since patients with stage 1E have a better prognosis than those with 1E or 2E or higher. In addition, MALT lymphoma has a better prognosis than DLBCL. Then a question arose in my mind, are there any differences in prognosis according to background thyroid autoimmunity status and genetic polymorphism? Since we did not perform genetic evaluations, we focused on background thyroid autoimmunity. So we conducted a study and published this paper in 2022. The primary objective was to examine the clinical features and pathological findings of PTL patients according to background thyroid autoimmunity status, which includes Graves' disease, Hashimoto's thyroiditis, and without autoimmune thyroid diseases, or AITD. The secondary objective was to examine the long-term outcomes of the patient with PTL. Between August 1979 and October 2021, 610 patients were diagnosed with malignant lymphoma according to pathological findings from thyroid specimens acquired by open biopsy or wider surgical procedures, such as lobectomy and total thyroidectomy. The clinical stage was evaluated by imaging modalities including computed tomography, gallium-67 scintigraphy, positron emission tomography, and bone marrow aspiration biopsy. As a result, 112 patients were classified into stages higher than 3E. Subsequently, 498 patients were diagnosed with PTL, and they were the participants in the study. It was also confirmed that they had not been diagnosed with malignant lymphoma previously, so that thyroid site was not a relapse of previous disease. So these pie charts show the characteristics of all patients. From left to right, each chart shows the distribution of sex, pathological diagnosis, and stages. 80% of the patients were female, and the pathological distribution showed that 55% were MALT lymphoma and 44% were DLBCL. Since DLBCL mixed with MALT lymphoma contained DLBCL tissue, which is clinically more aggressive than MALT lymphoma, so DLBCL mixed with MALT lymphoma was classified as DLBCL. Follicular lymphoma was seen in only 1%. So about stages, 44% of the patients were stage 1E, and the remaining 56% were stage 2E. The median age was 68 years, and the median follow-up period was 6.2 years. Then we classified these patients by their background thyroid autoimmunity status. As a result, Hashimoto thyroiditis most frequently coexisted with PTL, since 86.5% of the patients had Hashimoto thyroiditis. Graves' disease accounted for only 1.8%, which is 9 of 498 patients, and 11.6% of the patients had no AITDs. So these pie charts show the distribution of the pathological subtypes and stages of PTL. From the left to right, each chart describes the total patients, the patient with Hashimoto thyroiditis, the patient with Graves' disease, and the patient without AITDs. Looking at the chart of the Hashimoto's group, you can see similarities in the distribution with the total patients. Because Hashimoto thyroiditis accounted for a large percentage of the total patients, the actual percentage of MALT lymphoma and DLBCL was the same as the total patients. In the Graves' disease group, MALT lymphoma accounted for 67%, which is a higher percentage than in the total patients. This may be because of the small number of patients, although the difference in the distribution was not significant as the p-value was 0.51. The patient with PTL with no AITDs showed similar proportions of pathological subtypes to total patients. When we look at the stages of the patients, the ratio of 1E and 2E was almost the same in the total patients and the Hashimoto thyroiditis group. 67% of the patients in the Graves' disease group were in stage 1E, compared with 31% in the group without AITDs. Then we compare the distributions of pathological subtypes according to the background thyroid autoimmunity status. When the distribution of the pathological subtypes in patients with Graves' disease was compared with that in patients with Hashimoto thyroiditis and without AITDs, there were no significant differences among the groups. In addition, when comparing the distribution between the patient with any AITDs, which are Hashimoto thyroiditis and Graves' disease, and those without AITDs, there also were no differences. Originally, our study focused on the PTL patients with Graves' disease, and thus we collected further details of the 9 patients. So this table shows the characteristics of the 9 patients with PTL and Graves' disease. 8 of 9 patients were female, and the median age was 64 years, ranging from 45 to 81 years. Only one patient, patient number 8, had a positive TSH receptor antibody at the diagnosis of PTL, and he was the one who was diagnosed with Graves' disease and PTL at the same time. All 9 patients were positive for at least one of the antithyroid antibodies, which are antithyroglobulin and antithyroid peroxidase antibody. The median time required between the Graves' disease and PTL diagnosis was 13.3 years, ranging from 0 to 40.9 years. Patient numbers 1, 2, 4, 5, 6, and 7 were in remission of Graves' disease at the time of PTL diagnosis, and patient numbers 5 and 6 were on thyroid hormone replacement therapy with levothyroxine. Patient numbers 3 and 9 were on antithyroid medication at the time of PTL diagnosis. Patient number 8 started treatment for Graves' disease with potassium iodide soon after the diagnosis of Graves' disease, although suspicion of PTL led him to choose total thyroidectomy for the treatment of Graves' disease. To make a definitive diagnosis, open biopsy was performed for 6 patients, and total thyroidectomy was performed for 2 patients as a treatment for Graves' disease. Lobectomy was performed for 1 patient because the tumor was located on the dorsal side of the thyroid, and it was difficult to detect from the superficial appearance. As I showed earlier, 6 of the 9 patients were diagnosed with MALT lymphoma, and the remaining 3 were DLBCL. The thyroid specimens from 3 patients who underwent lobectomy and total thyroidectomy were fully examined. Pathological findings showed typical characteristics of representing Graves' disease on the left and Hashimoto thyroiditis in panels B1 through B3 on the right. In the tissue with characteristics of Graves' disease, you can see an enlargement of thyroid follicles and lymphocyte infiltration. In the tissue with characteristics of Hashimoto thyroiditis, you can see focal infiltration of the gland by small lymphocytes and plasma cells in B1. Thyroid follicles in the areas of inflammation are atrophic and lined by swollen and degenerated follicular cells in B2. And epithelial cells with abundant eosinophils, called Hurther cells, are occasionally seen in B3. As a treatment for PTL, radiation, chemotherapy, and combined modality therapy were selected for each patient depending on the pathological diagnosis and the stages. Since each diagnosis was made in a different era, the treatment protocol was also different. And because of that, even patients who had the same pathological diagnosis and staging received different treatments. Radiation, abbreviated RT, was performed for 3 patients, 2 with stage 1E MALT lymphoma and 1 with stage 1E DLBCL. Chemotherapy was selected for 1 patient with stage 2E MALT lymphoma. Combined modality therapy was performed for 3 patients, 2 with stage 2E DLBCL and 1 patient with stage 1E MALT lymphoma. 2 patients with stage 1E MALT lymphoma who underwent total thyroidectomy as curative treatment for Graves' disease did not require additional treatment for PTL. Hence, close monitoring with blood testing and ultrasound was planned for them. All 7 patients who underwent treatment for PTL achieved complete response, though patient number 2 relapsed with lymphoma 2 years later. So finally, we compare the prognostic outcomes of the PTL patients with Graves' disease, Hashimoto thyroiditis, and without AITD. For the long-term prognostic analysis, 32 patients whose follow-up period was less than 90 days were excluded. Thus, 466 patients with PTL were analyzed. This analysis included 9 patients with Graves' disease, 404 patients with Hashimoto thyroiditis, and 53 patients without AITDs. For the outcome analysis, relapses and deaths were recorded as outcome events. There were 40 relapses and 48 deaths. Of the 48 deaths, 17 died from PTL, and the remaining 31 patients died from other causes. Major relapse sites were 20 in the thyroid, 4 in lymph nodes, 4 in the liver, and 3 in the central nervous system. Overall survival and event-free survival rates by Kaplan-Meier curve analysis are shown in this table. In the total patients, 5-year and 10-year overall survival rates were 92.4% and 88.8%, and 5-year and 10-year event-free survival rates were 87.8% and 81.2% respectively. The Kaplan-Meier curves show the comparison of the overall survival and event-free survival rates by background thyroid autoimmunity status. Figures A and C show overall survival, and B and D show event-free survival. Figures A and B compare the groups of PTL with Graves' disease and those with Hashimoto thyroiditis, and figures C and D compare the groups of PTL with Graves' disease and those without AITDs. In this analysis, we did not find any differences in 5-year and 10-year overall survival or event-free survival rates between the groups, suggesting no differences in prognosis based on background thyroid autoimmunity status. In summary, PTL was observed with Hashimoto thyroiditis in the majority of cases, rarely with Graves' disease, and the remaining cases had no AITDs. No significant differences in patients' age, sex, follow-up period, and pathological subtypes of PTL were seen based on background thyroid autoimmunity status. Prognostic analysis for all patients showed a 5-year overall survival rate of 92.4% and a 10-year overall survival rate of 88.8%, showing good prognosis. Long-term prognostic outcomes of PTL did not differ according to background thyroid autoimmunity status. As limitations, this was a retrospective study, and the number of patients was still small, and the study included only Asians, particularly Japanese patients, and genetic examinations were not included. So a study that includes a larger number of ethnically diverse patients with genetic information will be needed. Now our discussion. So chronic inflammation and lymphocyte infiltration due to Hashimoto thyroiditis are considered to be the basis of PTL. So the lymphocyte infiltration is one of the characteristics of the histopathology of thyroid tissue of Graves' disease. Then it could be assumed that the thyroid tissue of patient with Graves' disease might be a basis for PTL. Another possible explanation was the fact that the 9 patients with PTL and Graves' disease our study were all positive for at least one of the antibodies for Hashimoto thyroiditis. In addition, Takakuan and co-authors showed a relationship between FAS gene mutation and PTL and Hashimoto thyroiditis. It is known that FAS is a cell surface receptor expressed on activated T and B lymphocytes, contributing to cell death signaling. And due to this role, mutation of the FAS gene leads to an accumulation of lymphoid cells in tissue. They reported that mutation of the FAS gene was detected in 65% of the thyroid lymphoma tissue and 27% of the tissue of Hashimoto thyroiditis. And they suggested that accumulation of lymphoid cells in Hashimoto thyroiditis with FAS mutation provides a basis for the development of PTL. So in our study, 11.6% of the patients with PTL did not have AITDs, and no differences in pathological diagnosis and prognosis were seen between the patients with and without AITD groups. So in 2021, Wu and co-authors reported a genetic profile of thyroid lymphoma in Leukemia Journal. And this study was actually a collaborative study with Ita Hospital as we provided thyroid specimens of PTL. So in their study, they searched for genetic mutations in various types of MALT lymphoma using 93 gene panel sequencing. The results showed that TET2, CD274, and TNF-RSF14 mutations were most frequent in thyroid MALT lymphoma, and together with deletion, CD274 genetic change accounted for 68%. In addition, a significant association between CD274 mutation deletion and TNF-RSF14 mutation was found. Moreover, a significant association between both CD274 and TNF-RSF14 genetic changes and Hashimoto thyroiditis was seen. Furthermore, the results showed that CD274, TNF-RSF14, and TET2, which were the most frequently seen gene mutations in thyroid MALT lymphoma, were not or rarely seen in MALT lymphoma of other sites. In this figure, the upper 3 rows show CD274, TNF-RSF14, and TET2 from top to bottom, and the original sites of MALT lymphoma are shown in the columns as thyroid, ocular adnexal, salivary gland, and gastric and others. It is easy to see from this figure that CD274, the first row, and TNF-RSF14, the second row, genetic changes are unique to thyroid MALT lymphoma. CD274, also known as PD-L1, and TNF-RSF14 are ligands for the co-inhibitory receptor PD-1 and B and T lymphocyte attenuator on T helper cells, respectively. So their inactivation may free T cell activities, resulting in promoting their support to malignant B cells. They suggested that the inactivation of CD274 and TNF-RSF14 may provide a basis for the development of thyroid MALT lymphoma. And then, these genetic changes might be one of the causes of PTL in patients without AITDs. So in conclusion, PTL was observed with Hashimoto thyroiditis in 86.5% of cases, Graves' disease in 1.8%, and no AITDs in 11.6%. The proportions of each pathological subtype of PTL and the prognosis of PTL did not differ between patients with Graves' disease and those with Hashimoto thyroiditis or those without AITDs. So this is the end of my presentation. Thank you very much, and I really appreciate this opportunity.
That was an excellent talk, Nami. Thank you very much. There's not very much left for me to cover, in fact. So what I have is a short set of slides that are directed really at people who know nothing about this condition. And I do hope that fellows and young faculty will take a look if they're not online now, that they'll be able to pull them up and see them. So let me just get into this. So I do have some disclosures, none of them relevant to today. And I'll try not to be too repetitive, but obviously lymphomas occur outside the thyroid gland, and there are various origin, and each lymphoma seems to reflect the cell from which it's originated, right? And since autoimmune disease emerges from B cells and T cells, that's where the lymphomas within the thyroid gland come from. Autoimmune disease is associated with B cells such as myasthenia, and autoimmune disease associated with T cells such as diabetes are not particularly well known for their high rates of lymphoma. Hashimoto's is actually a T cell mediated disease, right? But clearly there are a lot of antibodies around. In contrast, Graves' disease is a B cell mediated disease. And you would therefore, following this logic, might expect a lot more lymphomas coming from B cell mediated diseases than T cells, since many of these lymphomas in all autoimmune conditions seem to come from the B cell side of the marrow. Now, the cause of the association, as Nami has beautifully outlined, is really not clear, right? And it's thought to hinge on this idea of genetic events that are triggered, I think, by inflammation, right? Now, the immune incompetence is part of having a lymphoma, but we're talking now about a highly localized lymphoma rather than a generalized lymphoma seen in more systemic autoimmune diseases. So the idea is that autoimmune antigenic stimulation, right, which is the heart of autoimmunity, which leads to chronic inflammation, induces cytokine-mediated genetic changes, and the influence of cytokines on gene mutation is well established. And the result may be clonal expansion and in turn lymphoma development, probably requiring a series of different hits. Now, alternatively, turning it around, the immune deficiency of developing a lymphoma could promote the onset of autoimmune disease, but this is much less likely in an organ-specific autoimmune disease than in systemic diseases such as SLE. And other factors may include, we don't have time to go into everything, but the host of immunosuppressive therapies today can also precipitate lymphoma formation. But again, these tend to be systemic rather than localized to the thyroid gland. So I like this title, Time is of the Essence. My wife's a lawyer. They love it also. But it applies to very much to research. It applies very much to care of your patients, that you have to make some decisions, and it's often based on poor information. Anyway, in this context, time indicates that patients have Hashimoto's thyroiditis before developing a lymphoma. In most of the cases, 65% from what I read, right? Whereas lymphoma coming after, getting autoimmune disease after the lymphoma, presenting with a lymphoma, and then going on and developing autoimmune thyroid disease is unusual, right? And the two together present to the clinician quite often, and that's one of the problems with Hashimoto's thyroiditis, and that it's often diagnosed late. In fact, in Japan, if I'm allowed to say so, you only have to have thyroid antibodies and you're called Hashimoto's disease, right? Because he's a hero. And here we tend to reserve that more to people who have thyroid failure, have enough destruction of the thyroid gland to need thyroid hormone replacement. Anyway, this sort of clear epidemiology data clearly suggests that autoimmune disease is a lymphoma susceptibility state. And what that means isn't clear. So this is the sort of outline that most people would agree with, that there is polyclonal expansion at the site of the autoimmune response, and there's a high burden of inflammation with upregulation of a whole host of cytokines. And this leads to this phenomenon of clonal hematopoiesis, which is very much in vogue and is essentially the emergence of a clone of cells with some genetic changes, some of which may be dangerous, right? And this leads then to lymphomagenesis. So the genetic link that Nami reviewed nicely, and I'm glad I didn't go up that pathway, is this phenomenon of clonal hematopoiesis, which is the acquisition of mutations, inducing a variant clone, and it's clearly initiated by flowing pro-inflammatory cytokines. And this is more common in the aging population. In fact, as clinicians, we may have a number of patients, older patients, with peripheral blood showing clonal hematopoiesis. And the hematologists say, oh, just follow it, there's nothing to do right now. But occasionally that develops further into a lymphoma or to even more serious abnormalities. So I don't want to repeat too much of what we've already heard, but it is important to repeat so that people remember. Politicians seem to be very good at that right now. Seems to be the same stuff every day, said in different ways. So we've heard that almost all primary thyroid lymphomas belong to the B-cell lymphoma category, right? And that about 50% or more of the large B-cell lymphoma, right? So-called diffuse large B-cell lymphoma shown in that little diagram. And the other half, depending on your series, now we saw, I think, more than 20%, it's almost half and half, I think, are these marginal zone lymphomas called MALT, right? Mucosa-associated lymphoid tissue. And the rest are pretty uncommon, right? Follicular lymphomas, mantle cell lymphomas. So, as we heard, thyroid lymphomas are rare. They're 1 to 5% of thyroid malignancies. And they occur primarily in older females, not exhaustively, but certainly that is the population where you may suddenly be presented with a patient who has a very easily palpable, even visible mass, complaining of dysphagia, dyspnea, hoarseness, all the things we don't like. And also because it's a tumor, fever, night sweats, and weight loss may occur. Some of the weight loss just because they're not eating. And as we mentioned, about 50-50 for DLBCL and MALT. And Dr. Suzuki did the histology much nicer than me. My slide was merely to remind everyone that it's the CD20 staining that really marks the diagnostic, I think, for lymphoma. The rest is up to the pathologist to recognize the different cell types. And it's well known that I'm very skeptical of pathologists. Since Dr. Brandwein is not here, I can say that. And she's a wonderful pathologist. So, presence of Hashimoto's thyroiditis is found in over 80%, and it gives a 40 to 80-fold increase in risk. So that's a good reason for sonographing all your Hashimoto's patients, which insurance companies over here do not like, right? But there's still occasionally lymphomas occurring in the thyroid without thyroiditis. And Graves' disease is really unusual. It's remarkable that Nami has 9 cases, right? That must be the largest series in the world. And why is this? Well, I think those 9, and you need to go back with a pathologist and look again, because I think that many Graves patients develop on a background of Hashimoto's thyroiditis. And that's why they have the clinically measurable thyroid antibodies to thyroglobulin and thyroid peroxidase, which are secondary to cell damage. You do get Graves patients without those antibodies. And I suspect that they have very little thyroiditis. And it's the ones with thyroiditis that are more likely to develop Graves' disease. The other important thing that I haven't mentioned is, of course, Graves' disease presents very early because people feel ill. Whereas with Hashimoto's, they don't feel ill until you give them thyroid hormone and realize how bad they were, right? How much they'd slowed. So that the time span for lymphoma development in patients with Hashimoto's is quite long, whereas in Graves' it's rather short. And I do think still, despite the world's largest series, that the number of Graves' patients available for study is far too small to draw about clear conclusions on prognosis and etiology. But time may change that. if Dr. Suzuki keeps working hard. Diagnosis. Okay, so here I have to emphasize that fine needle aspiration is not a good way of making a diagnosis, and that we need to use core biopsies, just as you would for a liver or a kidney, a nice core needle, which gives you some tissue. You can do an open biopsy when you're surrounded by good surgeons like we are, and Dr. Suzuki is. You can do open biopsies and get definitive treatment, diagnosis, and identify the lymphoma subtype. And doing flow cytometry can help you prove that it's monoclonal, but not much else, I don't think. So surgery is not recommended for the treatment of primary thyroid lymphoma, right? It has no real role beyond diagnostic biopsies, but of course it may in fact be diagnosed by surgery, right? By unintended diagnosis, finding a accidental lymphoma on pathology, but there's no direct benefit of actually, I understand, taking it out. And maybe Nami Suzuki can talk a little bit more about that, since she comes from a hospital famous for its surgery. And the typical treatment we heard already is CHOP, cyclophosphamide, doxorubicin, vincristine, prednisolone, or rituximab, which is an anti-CD20 monoclonal treatment that's been available for quite some years now, and there are analogues of this monoclonal also under study, although I don't know personally how much use the newer rituximabs have been. So lastly, does Hashimoto's thyroiditis precipitate lymphoma development? The answer has to be yes, by the epidemiology, right? Because 65% at least have it before their lymphoma develops. It's hard to argue against that, right? And as I mentioned earlier, how come when it's a T-cell mediated disease that they're getting B-cell tumors? And it has to be secondary to the severe local inflammatory reaction, which we often underestimate is going on inside the Hashimoto's gland. And it's a great contrast to the Graves patient, who has a much less intense inflammatory reaction, already shown nicely, and again emphasized here, that in autoimmune thyroiditis or Hashimoto's, you have to have follicular destruction, not just a lymphocytic infiltrate. I mean, you have to teach the pathologists this, I'm afraid, right? That a lymphocytic infiltrate around a tumor is not autoimmune thyroiditis. There has to be follicular destruction, right? As you see on the left. Whereas on the right, in a patient with Graves' disease and some lymphocytic infiltration, it's much less intense. Now, it's often said that it's less intense because the patient's been treated, but there's no evidence for that. There's actually very little data on the pathology of Graves' disease before treatment. And my last slide, I think, yes, is how do we explain all this? So we say, as we keep saying, a lack of intense inflammation in the Graves' gland may be the problem. It could also be that thyroid cell activity protects the microenvironment around the gland. It could also be that there is a susceptibility gene to Hashimoto's thyroiditis that the Graves patients don't have. I'm a little less excited about that, since these are very similar diseases, occur in the same family, can occur in SIBs. So I don't have an answer to that. It's also possible, as I mentioned, first of all, the longevity of the disease is short for Graves. And also they get treated with methimazole, an antithyroid drug, which has a well-known immunosuppressive activity. And this may reduce the lymphocytic infiltration, or even more likely actually suppress or fuel or minor infiltrate they have. This lack of infiltrate in Graves' disease is well shown in the animal models of Graves' disease, where when you immunize with the TSH receptor, you get stimulating antibodies and thyroid overactivity. But the thyroid gland shows a few macrophages, but no real intense lymphocytic infiltration. Right? So it's quite a different phenomenon, Graves' disease, than Hashimoto's. So that's all I have to say. And thank you very much for the opportunity. I really valued the chance that forced me to learn something about lymphoma and the thyroid. And I think that it has a number of messages that are important for us as clinicians, as well as surgeons and researchers. Thank you, Mark.
Great. Dr. Davies, as always, I learned so much as soon as you begin to speak here. So thank you.
Thank you. That's what my wife says.
I'm sorry?
That's what my wife says.
So I have 3 questions, and I open this up for you. And this, I caution that this comes from the mind of a surgeon, which is always, I need to put that in as a disclaimer here. So my first question is related to the histology, and Nami, maybe you can answer this. It did seem like the diagnosis was established by the removal of the entire, at least the lobe of the thyroid. And I sort of want to get a little bit deeper dive into this mixed population of MALT and DLBCL lymphomas, where the biggest concern is, I guess, missing a DLBCL component here. Is that diagnosis based on the percentage, or is it an all or none phenomenon? That if you see DLBCL, even in a small percentage of the population of cells there, is that sufficient to make that diagnosis? And do you need the entirety of the gland in order to be able to rule that out?
Thank you for your question. So usually in a hospital, open biopsy is the standard procedure to obtain specimens. So however, when the patient show the small lesion of suspicious MALT lymphoma, primarily thyroid lymphoma, then, as I shown in the one case in the presentation, that if the how can I say, nodule is located on the dorsal side, or it is too small to detect from the superficial appearance, then we decided to go on lobectomy. So, and of course, the diagnosis of lymphoma was depending on the pathologist. So in the hospital, we have 2 doctors specialized in thyroid lymphoma. And so usually, how can I say, as for the diagnosis from both doctors, and then we decide the final decision, final diagnosis. And of course, some, as I show that, there is mostly, most common type is DLBCL, and the second common type is MALT lymphoma. And the third type is actually DLBCL plus MALT lymphoma. So in that case, we see the, how can I say, the partially the pathological diagnosis, pathological image show the MALT lymphoma, and it's, how can I say, gradually developing to DLBCL. We see that those gradual progress, not progress, the development, and one slide. So in that case, we make the doctors diagnose them as mixed with DLBCL plus MALT lymphoma.
Great. Thank you. So I have a question regarding the phenomenon that we commonly see in both Graves and in Hashimoto's, that often there are significant number of associated central compartment lymph nodes that are enlarged and presumably inflammatory. Do you ever see the development of lymphoma in those lymph nodes that are associated with the thyroiditis?
In my experience, I never seen those patients. I mean those condition.
So is it safe to say, and Dr. Davies, please feel free to enlighten me, this has to be more than a chronic inflammatory process here that is related to the underlying this happening within the context of the thyroid environment.
Well, it's stochastic in the sense that we don't really know where the hits are coming from, but it's an accidental development. That is the basis of our understanding of carcinoma, that it's stochastic, that there are different problems arising and errors occurring for no necessary reason except the process itself of maintaining the DNA is subject to error. So that would be my explanation, and this is accelerated by cytokine exposure. If it's going to arise in the lymph nodes, then you're really talking about a systemic lymphoma, like in SLE patients or rheumatoid arthritis patients. But I was a little confused now by Dr. Suzuki, in the sense that, are you saying that a patient, once you diagnose with an open biopsy, you would still go ahead and do a hemithyroidectomy?
Oh, no. If the thyroid nodule, I mean the suspicious lesion of lymphoma are too small, and then sometimes we recommend lobectomy. So usually we do, not I, but surgeons do open biopsy, just obtain a small amount of liver tissues.
I think we're out of time.
Well, let me ask my final question here, and that is, we got there is a 40 to 80-fold increase in the development of lymphoma in patients with Hashimoto's. I assume this is the longer you have it, the greater the risk of developing of lymphoma. So how do we follow patients with Hashimoto's? Do they need regular ultrasounds, and how do you advise patients with Hashimoto's that you're following them regarding this significantly increased risk? And actually, maybe you can tell me what percentage of Hashimoto's, we know there's a 40 to 80-fold, but what percentage of the entire pool of Hashimoto's patients ultimately develop lymphoma?
I think it's incredibly small. It's incredibly small.
So in my presentation, and there one of my the co-author of my paper showed that it was 0.56%.
Okay, all right. So does a Hashimoto's patient require regular, whatever that term means, surveillance with ultrasounds?
Well, I work on the Upper East Side of New York, and the patients ask for ultrasounds where we work, and it's going to vary very much on the level of medical care you're applying. In my 40 years in practice, I've seen one lymphoma in the thyroid gland, so I'm not going to frighten all my elderly ladies and say you're going to develop a lymphoma, we have to ultrasound you all the time every year. No, I would hope that thyroid hormone replacement will keep the gland quiet, and hopefully nothing will happen, which is apparently the norm, right? So if you feel anything on palpation, then you're going to be doing an ultrasound. And if they do have nodules, right, in the Hashimoto's gland, that can be of some concern. Must be biopsied at least, and maybe followed. We don't like nodules in Hashimoto's glands. I don't like nodules in Graves' glands, right? They're often a sign of something bad. So, you know, you've got to go to a physician who knows what he's doing.
Great.
And
All right.
regarding,
I'm sorry, Nami.
so regarding our patients with PTL and Graves' disease, 9 patients, six of 9 patients have huge goiter and developing the enlargement of thyroid, and that's why that is the reason that we did the ultrasound. And other 2 have they have the nodule. And so then we did the ultrasound as a usual monitoring of the thyroid nodules.
Great. Terrific. Listen, thank you both very much. Dr. Suzuki, thank you for all the work that you put into putting this research study together. And Dr. Davies, thank you for agreeing to participate. I want to thank our audience for joining us. This was highly informative, and look forward to seeing you next week, same time here. Very good. Thanks so much. And everybody have a great day and stay safe here.